Joakim, thank you. For those of us who could hear, that was a real tour de force through the literature surrounding minimally invasive techniques for Dupuytren's. I'm sorry that lots of people have been having sound issues. I have tried to do what I can on my side. I'm not sure there's much more that I can do. The talks tonight are all MP4s, so no one is speaking live, so they can't move closer to a microphone or anything like that. What I will say is that the whole webinar is being recorded, and we will be publishing it on the Icoplast YouTube platform at some point in the next few weeks when I get a little bit of time to edit the videos back. And so hopefully they will come out with clearer sound there. So I do apologize for those of you who've been having problems. So let's kick off with the Q&A. Joakim, you are on mute, so you may want to unmute yourself, ready for the first questions. We've got some questions in the Q&A from the audience. Heinrich Siegenschmidt.
Let's start by adding one thing, is that one of this Dr. Baudrillard, he actually reached out to me between the recording, and he told me that their study is ongoing, the French study as well.
Right. So we definitely have some studies in the pipeline, and Heinrich Siegenschmidt, who many of you will know as an expert in radiotherapy from Germany, is wondering about future options to integrate minimally invasive procedures with radiotherapy. Joakim, do you know anything about these? We have a seminar coming up on that, but
I'm sure I'm going to listen to it, but I don't know very much about radiotherapy at all for Dupuytren's, and it might be a suggestion, but once again, I'm ignorant about this.
Paul, you have some.
No, I'd like to comment on the question of Heinrich. There is quite a big effort taking place at the moment in Australia, and it is headed by Martin Jarrett of Newcastle, New South Wales, and they are doing a study in which they are looking into the efficacy of and durability of radiotherapy for primary disease, and in the combination with needle fasciotomy or limited fasciectomy or collagenase. Obviously, the last arm is going to be a bit difficult because collagenase has also been removed from the market in Australia. But we're very much looking forward to the, I think it's the last webinar, is it, Dominic, about radiotherapy?
It's in 4 weeks' time. So I think it's webinar number 4. So yeah, we're looking forward to that one. We have a whole evening all about radiotherapy, so please do tune in to that. So we have some other questions. One about novel treatments. Again, we have a webinar on novel treatments right at the end of the series in December. Patrice Smith is wondering about alternative medicines, traditional Chinese medicine, acupuncture, massage, chiropractic, that kind of thing. Anyone researching that?
Okay. My answer to that must be the same as to radiotherapy, that I'm not aware of any studies this far on the subject.
And it looked like your pretty comprehensive search of clinicaltrials.gov, etc., didn't pull out any ongoing studies. Okay, thank you. David Gorman is wondering about how recurrence occurs after both of these minimally invasive treatments. So do you get a new nodule, or does it just go on and form a new cord again? What's your experience with that?
I think one thing that hasn't been really, that I haven't found much in literature, I know that Paul Worker and co-worker has written about it, is that in our study, that in 50% of the patients after 5 years, there were no signs of any cords left. So in some patients, there is a sort of the collagenase disappears in some of these patients, and nobody has ventured into this far. But I think personally that there is a new cord, an entirely new cord, that is that's gives recurrence.
Gary, do you have any other thoughts on that? You've done a lot of these procedures.
I agree. I think that it is a new cord that usually develops. You know, in my experience, even after collagenase or limited fasciotomy, the nodules are not are not gone. So you may still have the retention of the nodule. And that's one of the things that Dr. Worker and I worked on in defining recurrence, and the Delphi project did as well, to make it clear that a nodule was not the indication of recurrence. But I do agree. I think it's new cords that form either between the nodules or in other places. And that's usually what brings on that recurrence.
Paul?
Yeah, thank you, Gary. In some of my patients, I only used collagenase in 50 patients, and it never was reimbursed in Holland, so I don't have huge experience. So my experience is related to a needle. And in some of my patients, the patients tell me that after the cord was interrupted, that the nodules did disappear. And I wonder if you recognize that situation. And I was wondering, does anybody have a clue why in some patients they disappear and in others they don't?
My gut feeling was when the tension was removed from the nodule, and that could happen with, you know, fasciotomy or with collagenase, that when that tension's removed, somehow the nodule can resolve. It's kind of calming down. I know there has been collagenase studies in the United States on injecting into nodules. As far as I know, there's none, you know, no major study that's been published to see if it really had an effect on nodules directly.
Thank you.
Okay, thanks. We have some questions from some patients who've tuned in. Mark Purcell said he thought the average cost savings of needle fasciotomy would be more than what you showed on your slide, Joakim. I must say I thought that as well. I thought 33,000 euros was a lot for the cost of a needle fasciotomy. How are those figures derived?
They were used. We calculated all the costs for, and we also did both procedures in this study in a minor operating theater room in the outpatient ward, and that might be so. This, I agree that probably the cost difference is a lot larger. But in this study, where we had this setting in a minor operation room, this was the actual difference. But I'm sure there is a lot greater.
And they were the direct healthcare costs, not the costs of loss of income and things like that for the patient. Wow. Okay. Daniel Ray has said, when recurrence is mentioned, does it include extension of disease? So you treat one finger and it extends and recurs in a different finger.
Not many of these studies, actually. These randomized studies only deals with one finger, and recurrence is not extension.
I 100% agree. You know, in the Delphi study and other, you know, projects that have been worked on, though extension is obviously an issue and a problem, it would not, you know, if you're treating a 30-degree MP joint and now you have a 30-degree PIP joint, it really is, it's extension of the disease as opposed to recurrence for that joint.
Okay, Francois Liu has nicely anticipated a paper that's coming later on in the webinar. Did the severity of the contracture have any impact on recurrence? Please wait around for Dr. Motoroko's paper, which is coming soon for that. And then we have Bernard Kane, who's given us a story of what it feels like really to be a Dupuytren's patient, and mentions that the recovery, especially after skin tears from collagenase, can take a long time. What's your thoughts on that, Joakim?
That's true, but in my opinion, in these patients we've treated, the skin ruptures are transient and they heal within 2 or 3 weeks. But of course, there are differences in this. But generally speaking, I think that skin tears are just minor complications. But some patients have a lot less better.
Yeah. Maybe your patients might disagree with you. I don't know. Jesper Nordenskjold, I'm really sorry about the pronunciation, but you mentioned his papers in your talk, and he's here with us this evening and wonders whether there are any types of contracture pattern, Joakim, where you might consider collagenase a better option than needle fasciotomy, or do you think it's just you would never use it?
I believed that for PIP joint contractures, where there really is no cord, it's more like a thick mass of collagenase. I thought that would be a better indication for collagenase, but then Skove's article proved me wrong this far. But I think that, in my opinion, for some PIP joint contractures, where there's this mass of collagenase, perhaps collagenase would be better.
Gary, in your experience, are there things that you pick out? David Warwick, I know, talks about twigs, so very, very sort of thin cords versus logs, which are big fat cords, and thinks that those are more suitable. The twigs are more suitable for PNF.
I mean, Professor Warwick's emphasized the twigs versus the trunks, or the big logs, and certainly a nodule that is completely across the proximal phalanx is going to be very difficult with needle to separate it from the neurovascular bundles. And you can do, I'll show a slide later about transverse injection of collagenase, but in my hands, it's almost interchangeable. I'm pretty much feel that I can pretty much do either one to the hand, but certainly the very thicker logs, tree trunks are much easier to do with collagenase than with fasciotomy. And scarring. If there's previous scar, it's often easier with collagenase. It does something with the scar as well.
I would like to chip in my ideas about that. I know that David always talks about logs and twigs. But I think that is too much of a simplification, to be honest. I look more. I see Dupuytren more as a string of beads, and they what you really have to do is go in between the beads and divide the cord in between the nodules. So in fact, and only if you have, of course, it is true. Sometimes you have these sausages in the finger, but then I don't believe that either collagenase or a needle is a good option. For me, if I may say, a needle for me also is a way to sort of get a feel of what sort of patient I have under my hands, because and I think that's the same. That would also be true for collagenase. If you use one of these minimally invasive procedures and you get a very quick recovery, then that is a totally different patient than if it takes longer before he or she develops a recurrence. I said recovery, I meant recurrence. Sorry about that. And also, if the skin is involved, then the result often is not as good as if the skin is not involved. So I was wondering, Joakim, if in your trial you were all the patients sort of the same kind, or were they? Can you remember that, if there were people with severe skin involvement or no skin involvement? Did you make that distinction?
No, we didn't in the study. It was not an exclusion criteria, but I can't really remember that we had many of these really severe cases, because they usually have a PIP joint involvement if there is if it's such a grave disease. But one comment about the twigs and logs, and I've told Professor Warwick this before. We did an ultrasound on 39 of the patients in the study, and we found that the maximum width of the cords was 7 and 8 millimeters respectively, and I would consider that a log that could still be divided. I mean, 8 millimeters is quite thick.
I was actually surprised. I was actually surprised that you only found one area of separation. You know, when we do needle at multiple levels or collagenase at multiple levels, I thought you might see spaces at different places, but that wasn't your experience with the ultrasound?
No, not at all. It's just one singular space. Even if we'd done it I was surprised too, but yeah, so we need more morphological studies to understand this.
Sure.